When I started, it was a club of a few friends interested in CLL. Now it's a very quote-unquote fashionable disease for many reasons: biological, clinical, management, and I would say also the fact that we're living longer. So there are many more CLL patients around, and the life expectation is increasing. So the landscape is changing dramatically. Prognosis is crucial. In the old days, we knew that it was an heterogeneous condition. Some patients with stable disease, some having a very aggressive, but we didn't really have a grip on this clinical heterogeneity. So the prognostic areas change a lot because of biological markers. So if we want to, we could expand on that, but I think that is a key point. Now we have prognostic markers that can help us to define which patients have a likelihood of remaining stable, or being slowly progressive, or having a very aggressive disease. Well, we have many markers. I mean, it's been a dramatically changing scenario with many markers having prognostic implications. If we want to be practical, what we advise, and if I get to have a lunch debate on this topic, if it's really important now and which markers are important, the bottom line is that the real important markers are the 17p deletion and the p53 mutation. So if you have those markers and patients are progressing, these patients have a, I would say, a very poor outcome. So these patients should be identified and treated accordingly.
So how long could there be a period where you would not otherwise have been aware that these patients had a poor prognosis? If you didn't actually look for those markers, would these patients go untreated for a long period of time?
Well, but you know, that's it's a difficult point, but even today you wouldn't treat a patient only based on a biological marker. Even today, June 2014, we would treat a patient if the patient has a need to be treated, so the disease is progressing. The point is that if a patient is progressing and has these poor prognostic markers, then you've got to go for a more aggressive form of treatment, including even a transplant. So that is the point. It's not the marker itself that determines treatment. It's a disease progression, and if you have the marker, you have to treat it in a different way, or you should try to treat it in a different way.
Here at the EHA, we've been hearing about specific treatments, things like Bruton's tyrosine kinase, that seem to be making a difference. Could you put this into perspective?
Yes, this is a major turning point, I would say, in the management, clinical management of CLL. I mean, so far management has been mainly based on chemotherapy associated with an anti-CD20 monoclonal antibody, so chemoimmunotherapy. Bearing in mind, and this is very important, that most patients with CLL at the time of diagnosis are over the age of 70. So although 70 today is relatively young, they're not kids. And if you have to treat an over 70, you have to consider that patients are less fit, they have comorbidities, so it is more complicated. So chemoimmunotherapy, where the most utilized combination is that, how can I say, relatively toxic. So if it's okay in a young patient, in an over 70, 75, 80, it can be difficult or not doable, in fact. Now, the new drugs you mentioned are extremely important because they are the first drugs that are in fact targeting a mechanism. They're not chemotherapy. So they're targeting a signal that goes through what we call the B-cell receptor, which is important in maintaining the proliferation of the leukemic clone. So we're targeting the pathway through the receptor. So it's what we call it a mechanism-driven form of treatment. It's not exactly like imatinib for other, or the tyrosine kinase for CML, where you have a genetic defect. CLL does not have one defect. So, but we are targeting the B-cell receptor. So these drugs are opening a new scenario because they can control the disease. So it is a major change. Now, we have much more, as I mentioned, indication of these biological markers having a very important prognostic implication. So if we identify a patient who has a progressive disease and has, let's say, a p53 disruption, whether this is a 17p deletion or a p53 mutation, these patients need to be treated aggressively. with the best possible treatment, which today includes an allogeneic transplant. If you can do it, if you're 80-year-old, it could be obviously difficult, but if you're 50, 60, we would consider transplant as in the algorithm of first treatment. The new drugs are opening a very interesting debate, because there is a suggestion that these new drugs targeting the BTK or let's say the B-cell receptor signal could be effective even in patients with these poor prognostic markers. I would say this is a bit early days, and we have to wait more and see in the long run if this is the case. I think too early to say. What is, going to your specific question, is, for instance, there are drugs that are targeting the BCL2. CLL has an overexpression of BCL2, and now there are drugs that are anti-BCL2. So that again targeting a mechanism. And this seems to be another potential and very effective way of treating these patients. Still early days. Again, early days. We can't choose yet. These drugs are not available yet. I mean, they're starting to be available, some in the States, but very early days. Now they are in Europe, they're at the European Medicine Agency, but we don't have them yet. We have clinical trials. So that is okay. We can put patients in clinical trials if they're open, but they're not yet widely available. And the indication, if we take one of them without making too many names, I mean, one is approved in the US, but for second-line treatment across the board. So it's independent of prognostic markers. So I guess the indication in Europe probably, we don't know yet, could be the same. We'll have to see, so we can't say now. That would not be for first-line treatment, that's for sure. It would possibly be for second-line treatment, but we have to see the indication. It would not be only for, it would be for any patient, irrespective of the biological markers. Now, we were mentioning earlier of the heterogeneous clinical course of CLL. We tell our younger trainees or fellows that a considerable proportion of CLL patients should not be treated, and a considerable patients with CLL may never be treated. So you can live with CLL and die not of CLL, but of other causes with CLL. So you can survive with a notable amount of leukemic cells. This is very relevant, I think, particularly since most patients are elderly. So you can live with a disease like CLL. And you can only treat when they progress. You shouldn't treat earlier than progression. That's a good point, because I started a few years back, and the policy was exactly that. Watch and wait. When the disease progresses, you're treated. 30 years later, it's the same. We still do not treat prior to progression. When the disease progresses, we should have some biological markers that should guide us on treatment, but not to give treatment before, but to guide us on the optimal treatment when we need to start. Per se, today we say no. The patient has to progress. And there are some patients with a P53 disruption who are not progressing, so you have to wait. What is becoming important and relevant is that probably the percent of patients harboring a P53 mutation is higher than we thought. So this should be, in an ideal world, we discussed it in the lunch debate, in an ideal world we would like every patient that goes to treatment to be tested. And this is not happening because it's cumbersome and the world is very big. We don't all live in lucky countries where we can do it. So most patients are not tested worldwide. Well, I mean, as we say, I think summarizing in general, I think you have to make a correct diagnosis. Even today, 2014, some patients come in and they're not accurately worked up. So first you have to be sure you're talking about CLL and not of a closely related condition which should be managed differently. So you have to be talking of CLL. B, it depends on where you live and the resources you have. If you're doing prognostic markers and you have to optimize resources, which is a key point today, I think this should be done at the time when you are deciding you need to treat the patient. If you don't need to treat, you can wait. The problem would be that the patient may ask you, because they go on internet. So they could see what I've read about these prognostic markers, will you do them? In theory, it's not necessary. We should do it at the time of progression. There, it would be advisable to do at least the FISH for 17p and, if possible, sequencing for p53, because that should guide treatment. Then you treat a patient. If a patient relapses, I think it should be again retested, because at the time of relapse, the incidence of p53 is dramatically higher. So that's very important. So that would be a flow chart, I would think. I can't go into treatment. It depends, obviously, on age, comorbidities. So that's complicated to decide now. New drugs are coming on the scene, but we're not there yet. It's a very exciting time. We're going to see major changes, whether the drug will be used alone or in combination, but we need more time. Well, yeah, I think it's after many years, it's a very exciting time for CLL, because we've learned a lot about the biology, and now we're starting to see new drugs. I mean, it's not impossible that in a short time we will consider even a chemo-free approach for CLL, as we are doing for other leukemias. So that could be a very important turning point.